Good afternoon and welcome. On behalf of Jagsonpal Pharmaceuticals Ltd, I, Ankit Dogra, along with my teammates from Medical Services, Dr. Deepika Chhabra ma'am, Mr. Mitra Saxena, and Zonal Sales Manager, Mr. Vijay Kumar, from Naari Division of Jagsonpal, have pleasure to introduce you to PRORETRO tablets, Dydrogesterone 10 mg, being marketed by Naari Division of Jagsonpal. Today, we welcome you to the second episode of Clinical Academic Exchange Series presented by Practical Obstetrics Committee of FOGSI in association with Obstetrics and Gynecological Society of Ajmer, Alwar, Jaipur, Udaipur, Jodhpur, Bharatpur, Hanumangarh, Sri Ganganagar, Kota, Bikaner, Deoli-Sawangi, Rajpur, with the academic partner Naari Division of Jagsonpal Pharmaceuticals Ltd, makers of PRORETRO tablets containing Dydrogesterone 10 mg and Fibristone 25 containing Mifepristone 25 mg for fibroids. This webinar is granted 2 ICOG credit points. We thank ICOG office and the FOGSI office bearers for organizing this webinar on intrapartum surveillance with stalwarts in the field. We welcome the Chairperson, Practical Obstetrics Committee of FOGSI, Dr. Mitra Saxena. She is the Senior Consultant Obstetrician from Rewari. We welcome the esteemed faculty and welcome all the attendees. Dear attendees, please post your queries by text in the Q&A box. Please note, this webinar is streaming live on Facebook and the link has been shared in the chat box now. The YouTube recording will be uploaded on Jagsonpal Medical Insights, our YouTube channel, for reference and promotion. Now requesting Dr. Mitra Saxena to kindly initiate the program. Over to you, ma'am.
Thank you, Mr. Ankit. A very good evening to every person who has logged in. I take immense happiness and pride in welcoming you all for this wonderful webinar on CTG. It's a very happy occasion that our chief guest, Dr. Alpesh Gandhi, Dr. Leela Vyas, Dr. Anju Soni, Madam Veena Acharya, all have joined in. And in their presence, I will first request Mr. Ankit and the team to start the prayers to the God. May Goddess Saraswati empower us with all the knowledge. It is immensely a wonderful evening today when we are gathered for this webinar. I take this opportunity to thank the FOGSI office bearers, our president, Dr. Shantha Kumari, our General Secretary, Dr. Madhuri Patel, and my Vice President, Dr. Kawita Bapat. They are always inspiring and encouraging the chairpersons to take academics and sincere learning to all corners of the country. Ably assisted, may I have the slide of our conveners, please? Today's program, wait, 1 second. Okay, so first of all, I will request the team to play our President's message, Dr. Shantha Kumari.
Dear friends, Foxians and women of my country, I am Dr. Shantha Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOGSI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Sri Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shantha Kumari as taking over the 60th president of this eminent organization.
Sri Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, women's health is neglected. It disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FOGSI's commitment towards women's healthcare. FOGSI for all, always.
FOGSI for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. FOGSI for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shantha Kumari with the theme FOGSI for all always and Dira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President FOGSI and also especially support her campaign, Dira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of FOGSI, declare my commitment towards women's health and safety.
Thank you. That is a very inspiring message by our president. And I'm sure every Foxian, all of us have believed in every word that she says. It's my privilege now, as the chairperson of the committee, to inform the August gathering who the conveners for this evening are. So, Dr. Surekha Taide, Vibrant, my West Zone Coordinator of Practical Obstetrics Committee, and from Sawangi Wardha, and Dr. Asha Jain from Raipur. They are the two people who have worked tirelessly to make this evening very fruitful event for academics. Please give me the slide of Dr. Alpesh Gandhi. So friends, now the wonderful job of welcoming a person very, very loved by every Foxian. Our chief guest for today is none other than immediate past president, Dr. Alpesh Gandhi. All of us have witnessed how this person has proved to be a man of crisis. Crisis doesn't come in some obvious way. Sometimes it just imperceptibly seeps in like something invisible and yet devastating. So, in the corona times, we have seen how this resilient, very intelligent, and very inspiring president took over and took the federation to greater heights, despite all the problems that we encountered in COVID times. And it is a very happy, coincidence for me that Dr. Alpesh Gandhi was also the chairperson of Practical Obstetrics Committee. And I still remember, and I'm sure everybody remembers, how he brought critical care to Central State. Actually, Dr. Alpesh's CV is very long because in his long span, he has achieved a lot. And however, we have just confined his major achievements. And I would like Dr. Alpesh to please give his good message and blessings and wishes for this webinar. Dr. Alpesh.
Thank you, Dr. Mitra, for the kind words, generous introduction, and for the invitation for this very, very important topic, which is very close to my heart. This topic is very close to my heart. I am thankful to Practical Obstetrics Committee, Dr. Mitra Saxena, Chairperson, conveners of today's program, Dr. Surekha Taide, Dr. Asha Jain, for giving me this opportunity. It is happy to see that so many societies, 12 societies, are working together, partnering with each other for this very, very important, noble subject. It is always good our different FOGSI affiliated societies work together for the same cause, same purpose. Pregnancy is a time of great happiness and joy for all expectant parents. Experiencing a stillbirth or a death of a baby or a preterm baby or a baby in incubator is always a silent tragedy for mothers and families, fathers and families. Surveillance is defined in our Oxford dictionaries as close observation, especially if suspected. Certain fetuses are at risk when particularly there is FGR or severe oligohydramnios, or when there is severe preeclampsia or gestational diabetes mellitus and many other such conditions. But we all know that any pregnant woman can develop complication at any time. Similarly, any fetus can have risk at any time during the pregnancy. So fetal surveillance during intrapartum period, antepartum period and intrapartum period is necessary for all the pregnancies, whether it is high risk or not, to reduce perinatal morbidity and mortality. At the same time, on the other hand, it should not translate into unnecessary iatrogenic preterm delivery. There are so many different methods of fetal surveillance, different techniques currently are available to predict fetus at risk or to prevent a poor outcome. We should use all these methods. Available methods should be used judiciously in all pregnancies with or without risk factors in order to avoid an adverse outcome. The role of intrapartum surveillance, particularly partogram and CTG monitoring, is now well established, and we all should learn both the things. Anurag Prakasre, a very famous person, once told that I can go days without talking to you, months without seeing you, but not a second goes. By that, I am not thinking about you. The about quote is exemplified the word fetal surveillance. Techniques for observing the fetus may vary, but surveillance should be uninterrupted to get the best possible outcome, whether pregnancy is high risk or not. Pregnancy across worldwide, the stillbirth rate has been falling from approximately 35 days per 1,000 live births in 1980 to approximately 50 days per 1,000 live births in 2015, but still it is not desirable, particularly in lower middle income countries. Still in world, it is estimated that 2.7 million neonatal deaths and 2.6 million stillbirths every year across the world, and 98% of these deaths are in low income countries. Approximately 75% of stillbirth occurred preterm, living in most deprived areas, and most of the complications occur during intrapartum period. This webinar aims to cover all the relevant topics, important topics in antepartum and intrapartum fetal surveillance. The topics have been covered by eminent clinicians, well-known authorities across India. The webinar is very comprehensive and will aid both the young and seasoned obstetricians. I congratulate the organizers. I am also delighted to see my friend Dr. Leela Vyas and a very respected Dr. Veena Acharya as guest of honor, and Dr. Anju as special guest with me today. And we have very eminent faculties who are going to talk today, Dr. Mitra Saxena, Dr. Asa Jain, and at the end we have a very interesting panel, case-based panel on CTG, going to moderate by Dr. Surekha Taide with many eminent panelists. I am sure today we will have a very, very interesting and session, and I wish all of you happy learning. And once again, I congratulate the organizers for this wonderful job and wonderful webinar. Thank you very much.
Thank you, sir. Thank you for this wonderful message. We are really overwhelmed with your deep, thought and insight into how fetal surveillance is such an important part. Dr. Surekha, please invite.
Thank you, Mitra Ji. And thank you very much, Dr. Alpesh sir, for accepting our invitation to be the chief guest of this program and guiding us and blessing us with your wisdom. And I would, on behalf of everybody who's attending and all obstetricians from India, I would like to, thank you for bringing FOGSI to this level that now we have a permanent space in FIGO for oration for Indian obstetrician, and congratulations, sir, for being the first orator in FIGO and for that honor. So congratulations, sir. And with that, now I have the honor of inviting and introducing our guest of honor, none other than our FOGSI stalwart, Dr. Leela Vyas, ma'am. She has been a great inspiration to every one of us. She has been encouraging youngsters like anything, and everybody knows her dedication to her quality care in to maternal health and how she has worked in Manyata. She has been the past vice president of FOGSI in 2018. Apart from that, she has held so many other positions in ISAR, in Naari, and she has been the president and secretary of Jaipur Obstetrics Gynecological Society. However, she has been the one who has been the inspiration for taking maternal health towards quality. Madam, we invite you for your pearls of wisdom.
At the outset, I convey sincere thanks to organizers, to the whole FOGSI team, and this Practical Obstetrics Committee Chairperson, a dear friend, Mitra, and Surekha and Asha, yeah, both of the conveners, they have organized, and for the last minute, I know they are hard work. And I congratulate Dr. Alpesh. ये सब कुछ आपकी देन है. And your tenure, you started to everyone come and join this webinar, and we have not felt that इतने दिन से हम मिले नहीं. We all were meeting, and really I congratulate Dr. Alpesh for doing such a hard work in a difficult time. And he succeeded in this successful programs. And it's very rightly said by Mitra that this practical obstetrics or the critical care in obstetrics is very near to Dr. Alpesh. And he has spread it message everywhere. Dr. Alpesh, we are in, for the long back, for more than 20 years, we are working together. And I remember that when he was chairperson also, we worked together. In his vice presidentship, we were working for the PPH cases. And now this process is going on, and we all are working, and everything has been explained by Dr. Alpesh. But so I'll just say that fetal surveillance, which is so important, that gives smile to a family. And definitely that smile reflects us, and we obstetricians have a good sleep after delivering that patients. And the CTG, yes, repeatedly these topics should be covered by all the stalwarts in this subject, masters in this subject, because day in, day out, we are going with the CTG. Our resident just call us, ma'am, CTG aapko WhatsApp kar diya, you see in that. So we always dependent on that. Even if we go with the fetal surveillance, as Dr. Alpesh said, that is required in cases of IUGR. We are not sending every day for that to go with your Doppler, because we require, yes, we will repeat it after 1 week, but in alternate days, CTG. And sometimes the patients are admitted, we are taking CTG repeatedly, and thus we counsel these patients that yes, everything is going on. So this topic is very practical, important, and I congratulate all our organizers, those who have done so hard work, and definitely this webinar will be a very useful for all of us. Thank you very much.
I welcome Dr. Veena ma'am. She is such an icon that it's very difficult to introduce her. When I started working in gynec oncology, she was the one who has always been there. She's sort of synonymous with Rajasthan. So she is an MBBS from 1973, MS in 78. She has a diploma in HIV/AIDS from Bangkok. She is a professor and unit head Department of Gynec and Obstetrics, SMS Medical College, Jaipur. Superintendent, Mahatma Gandhi Medical College, Jaipur. And her area of expertise, preventive oncology, reproductive medicine, maternal and child health, minor and major gynecology and obstetric surgery, colposcopy, and menopause care. So it's like it covers everything. I don't think there's anything left. So Veena madam.
Very good evening to all, and best wishes in advance for Diwali to all of this. I think that this year we have the great celebration of Diwali. I'm really thankful to Dr. Chairperson of today's committee, Dr. Mitra Saxena, and the convener of today's, Dr. Surekha and Dr. Asha Jain, for inviting me on such an important topic as a guest of honor and on the intrapartum surveillance. I'm sure today's webinar will be very fruitful and useful for not only for the practicing doctors, but it also very beneficial for the patients by preventing and giving the advice for the preventive oncology, prevention for the outcome of the baby, or prevent them from the adverse perinatal outcome, as Dr. Alpesh has told very nicely in detail about all the things. And timely intervention is rightly, he has pointed out, we will definitely save the life of the many babies. Today's we have so many eminent speakers and very nice panel discussion. I'm so happy, and there are more than 180 participants have already joined. So without wasting much time, I allow that. I'm thankful to the organizer who have given me this opportunity, and we are very happy to listen all the things from the eminent speaker. Thank you so much for inviting me.
Thank you, madam.
Thank you.
Thank you, ma'am.
Welcome, Dr. Anju. to our webinar. Dr. Anju is another person whom I know for her work in preventive oncology, and that has led to her prevention of HIV and AIDS Committee Chairperson post. She is the Secretary General elect IMS, President of JOGS in 2018-19. And more than that, you can see she's so dynamic. And when you are in a problem, I had a pregnant HIV patient and I called her up, now what to do? She got me in touch with the NGOs who looked after the patient, and even when the patient shifted to Delhi, she's still being looked after. So in spite of being a chairperson and being so busy, she's always been ready to help out whenever you are in a crisis. So it's my honor to welcome you here, Dr. Anju. Welcome, and we would wait for your blessings.
Thank you, Dr. Asha, for your kind words and introduction. At the offset, good afternoon to each and everyone present here. I'm so happy to see each and everyone. Dr. Alpesh, sir, I feel he's mentor to all of us. Sir, you have done a great job in your presidentship, and you made us work so much that, you know, we learned so much under your leadership. You are a dynamic leader, a great orator, a great academician, and last but not least, a critical care, you know, which was never there, existed in our country. You brought it, you know, in eyes of everyone. And we are so thankful to have you here with us in Rajasthan today. And beautiful Mitra Saxena, she is my name. She is a great friend. And the conveners of today's program, Dr. Surekha and Asha, Dr. Veena Didi, I can't call her Dr. Veena, I'll just call her Veena Didi, because I have grown up seeing her, you know, in my young days when I was young. So we respect her, and we respect her. And of course, star of Jaipur, Dr. Leela Vyas, not to forget our own president of Jaipur Obstetrics Society, Dr. Preeti Taru as her right hand. And of course, presidents and secretaries of all societies of Rajasthan, from Hanumangarh, Dr. Renu to Dr. Prerna, a new team of Shri Ganganagar, Dr. Nikita, and Udaipur. I just had a chance of meeting Dr. Madhubala. Such a warming welcome I got from her and Dr. Prakash. Jodhpur, Dr. Indra Abadi, and B.S. Jodha has been there with us all the time. And Bharatpur, of course, the new team, Ashok Verma and Manju Singh are doing great job again. Hanumangarh, Dr. Renu Sethia has been there for ages, and she's such a cooperative person, along with her secretary, Dr. Prerna. Ganganagar, I just said that we have a new team, Dr. Nikita with her secretary, Kota. Of course, Dr. Mamta Sharma is another person who gave a great welcome to me with Raksha, the Chulbuli Raksha of Kota. And Bikaner Sudesh is an old friend and a dear friend with Kamla and Deoli, Dr. Sawangi, and again, all the faculties who are there today. Now, when we talk of the stillbirth in our country, we have a very high rate of stillbirth, ranging to about 4 in per 10,000 birth. We have, though we have achieved come long way in decreasing the stillbirth rate, but when we look at the UNA reports in the world, we see that we top the 5 countries in the world, along with Pakistan and other developing countries. So this is where is the problem. We need to improve much further. And how do we do it? As Dr. Alpesh just said, that fetal surveillance has to be there, and it has to increase further. It has to not only be there with the private nursing homes or teaching centers. It has to be there at the periphery everywhere, and the knowledge of fetal surveillance has to go down to each and every pregnant woman, so that we don't have any stillbirths in our country. You know, it is very saddening and heartening news for a family when a mother keeps a fetus in her womb and they don't get the results of that fetus. That is really saddening for the family. So we have to do a surveillance, and the conveners have created a beautiful program, and I'm sure that program is going to benefit each and every person who is attending this program. my best wishes and congratulations to the whole team. And of course, my best wishes to Dr. Sulekha and Dr. Asha, who are trying to contest for the posts of chairpersons in FOGSI. Best wishes from my side. Thank you very much.
Thank you very much, Dr. Anju, for those very, very kind words, and also welcoming our 10 societies who have joined from all over Rajasthan here. We are very much thankful to them. And of course, Dr. Anju has done such a beautiful work on this virtual platform as a chairperson of HIV/AIDS committee, and we have benefited so much from the webinars and from all the knowledgeable activities she has conducted. Thank you so much, and thank you the chief guest and guest of honor and special guest for this beautiful inaugural. So with that, now we move on to our scientific session with our talk 1, which will be given by Dr. Mitra Saxena, and I would like to welcome our chairpersons for the first talk. Can I have the CV slide of the first chairpersons? So the chairpersons for today's, this is not the slide. We would like the slides of Dr. Preeti and Dr. Madhubala. So can I have the CV slide of Dr. Preeti? Dr. Madhubala is the medical superintendent. She was the medical superintendent and presently HOD OBGYN, and she has been a great teacher in the Medical College of Udaipur, and she has been a wonderful person who has actually led the department of obstetrics and gynecology in Udaipur. So can I have CV slide of Dr. Preeti? Dr. Preeti is the senior consultant in Kapun Hospital, Jaipur, and she is leading as a president of Jaipur Obstetrics and Gynecological Society. And I now invite Dr. Preeti to kindly introduce Dr. Mitra Saxena.
First of all, I would like to thank the Practical Obstetric Society of FOGSI to have given me this honor of being the chairperson here. And the greatest of all, of course, is to have the privilege to introduce Dr. Mitra Saxena, who hardly needs any introduction, basically. We all know her. We know her beautiful face, and we have just been listening to her sweet voice. Dr. Mitra Saxena is the chairperson of Practical Obstetrics Committee for the year 21-23, senior consultant obstetrician and director of Shri Ashwini Saxena Hospital at Rewari, Haryana. She is the past president and now patron of Rewari Obstetrics and Gynecological Society. She is the project director of Mukti of Haryana Obstetrics and Gynae Society to eradicate and educate, empower the women of Haryana from female cancers and unwanted pregnancies and STDs. And she is a national faculty with areas of interest in high-risk obstetrics.
Thank you. Thank you, ma'am.
So, yes, I think we all know Dr. Mitra.
Thank you so much. So, I think let us get started. I bring you greetings from Rewari city, which is a close neighbor to Rajasthan. Why is this not working? So I've been I'm going to be speaking about ABC of CTG. Friends, simplifying the understanding of complexities of CTG is the main agenda for this talk today. We all know that CTG is an integral part of every obstetrical unit, whether it is anywhere in the country or in the world, for any patient who is low risk, high risk, or any situation. And this is something which we cannot continue to be confused. We need to have good understanding. So the common difficulties in understanding CTG is the interpretation and the identification of the graph, and then correlating it to the status of the fetal oxygenation, have an idea about the fetal reserve, and extrapolating it to what the response of the fetus will be to the stress of labor. What we have to realize from pattern recognition to physiology-based interpretation. So in this talk of mine, I will try and correlate what are the physiological changes which are attributable to the changes in the graph. In labor, there is regular uterine contractions, which causes repeated transient interruptions of the fetal oxygenation. So healthy, well-oxygenated baby is going to be able to bear the stress of labor, and it shows itself as a reactive heart rate with acceleration, no deceleration. However, when the baby is compromised, the baseline shift in the fetal heart rate as bradycardia or tachycardia, no accelerations, variable decelerations, late decelerations, these all show, and most importantly, the loss of variability, which denotes a poorly oxygenated baby. So that is our main, aim. The fetus is sitting at the mercy of the system in the mother. So the fetus gets its oxygen supply and the nutrients from the environment, not directly from the environment, but through the system of mother's lungs, hearts, vasculature, uterus, placenta, and cord. So we can understand that the compromise can be from the maternal side, maternal disease, or in the vasculature, or in the local uteroplacental situation, or the umbilical cord, or the fetoplacental unit. Fetus itself may be compromised due to some genetic reasons or whatever. However, what is important is that it is Dil da Mamla. So let us remember that when we are looking at a CTG, it is basically what the fetal heart is going through. The whole graph is basically how the heart of the baby is responding to anything and everything. So if we go through the stress, whenever there is chronic respiratory or nutritive insufficiency, we have to understand that there are primary adaptive responses like decreased fetal growth rate, secondary responses in the form of, actually there is in the nature, there is a lot of conservation. So when there is compromise in the supply, the baby compromises its energy and there will be decreased fetal movement. Every point is very important for an obstetrician. If a woman says that she has decreased movement, our antennas should be up. And this could also manifest in the CTG with decreased fetal heart reactivity. Now, whenever there is compromise, obviously there will be efficiency in the fetal side, there will be redistribution so that the cerebral flow will not be compromised, and increased resistance from the umbilical side there will be improved flow in the brain, which we know as the brain sparing effect. Also, there is in fetus to cooperate with the hypoxemia, there will be in chronic hypoxia, there will be polycythemia. So actually at every level, there is some kind of a compensation until the insult or the stress is so much that the baby starts going into the decompensation. So from hypoxia to respiratory acidosis to metabolic acidosis. Now this continuum is what we are, as an obstetrician, we should be able to pick up before hypoxia and not allow the baby to be in acidosis and an unexplained IUD. Actually, basically in obstetrics, there's nothing like unexplained. So friends, our talk today and the whole session will be devoted to understanding everything and clear the confusions. So these are the factors which can affect the CTG, not just fetal compromise, but any maternal activity, posture, uterine activity. Suppose there's hyperstimulation, there's going to be a different effect on the CTG. If maternal temperature, again. Similarly, in fetoplacental age, it is very important to understand that the age of gestation of the fetus is very important to evaluate the CTG. What we have to remember that preterm babies, the baseline will be higher and post-term will be lower. So suppose if a patient who is 41 weeks and you take the CTG and the baseline is coming 160 or even 150, don't think it is normal, because 41 weeker, the baseline heart rate should not be so high. Similarly, we'll be coming to all these factors which will affect CTG in different ways. Now, also we have to understand that the CTG, the graph, is basically an interplay of the fetal heart activity depending on its physical activity. So during quiet sleep or in deep sleep, there will be a very stable baseline, and the accelerations are actually always because of movements. Whenever the baby moves, it increases the heart rate and manifests as accelerations, and the variability may not be very high, especially if the baby is quiet and in deep sleep. So whenever we are confronted with the CTG antenatally, where baseline is good but not too much of variability and not obvious acceleration, let us not jump to a conclusion that the baby is compromised. This is a normal finding in a quiet fetus. Similarly, in active sleep, this is the most frequent behavioral state, and there will be moderate number of acceleration because there is movement with normal variability. So friends, it is very important to understand that earlier than 32 weeks, the importance of CTG or the graph is not so much, because it is the maturation of the autonomic nervous system which manifests in the variations in the heart rate. So it is after 32 weeks that we start giving importance to the CTG. Now, what controls the fetal heart? We know that the autonomic and somatic components control the heart rate of the baby. The agreement between the sympathetic and parasympathetic is what constitutes the baseline fetal heart rate. Similarly, there is a constant fluctuation between the sympathetic, which will increase, parasympathetic, which will decrease. That creates the bandwidth or the baseline variability. Also, on top of it, if there is voluntary body movements by skeletal muscles, there is going to be an increase in the heart rate, which manifests as acceleration. Parasympathetic nervous system, we all know, is responsible for the activities for the body in rest. Sympathetic nervous system is always responsible for fight and flight. So how does a fetus respond to stress? A fetus, let us remember, a fetus cannot increase oxygenation to myocardium by increase in rate and depth of respiration as it is floating in an environment of amniotic fluid. The only way to respond to hypoxia is to slow down the heart. So a deceleration means that the baby is trying to conserve, so the heart rate has come down. So we have to remember that the fluctuations in the heart rate, the baseline and the beat to beat variability, they actually, if they move away from the accepted norm, we should be very much alert that the baby is trying to compensate. We cannot ignore a baseline shift from below to up or away. If there is unstable baseline, again, we have to understand what's happening inside. So quickly, we have to remember that the parasympathetic system is with baroreceptors and chemoreceptors. The baroreceptors respond to the stretch. So they manifest in the form of early decelerations, which are mainly due to mechanical stresses. In case the baseline is unstable or there is baseline variability is not there and the variable decelerations are repeated, then this may be ominous. Otherwise, they are quite benign. And about the chemoreceptors, we all know that chemoreceptors take longer to get stimulated and to recover back. So this is because of the change in the pH, change in the oxygen levels and the pH of the fetal blood, that these chemoreceptors which are present in the aortic and the carotid bodies will get stimulated when the uterine contraction is there. So the onset is delayed and the recovery, because when the uterus will relax, fresh blood will come and oxygenation will happen. Then these receptors will come back and the baseline will, the heart rate will come back to normal. So delayed onset and recovery during with contractions is chemoreceptor mediated. So these decelerations. So friends, the fetal heart is always going to respond by a increase or decrease in the heart rate. That's the only thing. So whenever it is early deceleration, it's a baroreceptor mediated deceleration. The late decelerations are chemoreceptor mediated, which shows that there is some progressive developing insufficiency. Hypoxia is there. We have to be alert. Very important to recognize and understand this type of deceleration. I will spend a few minutes to explain variable deceleration, because these are the most common type of decelerations occurring in 80 to 90% of all decelerations. They are variable because they vary in shape, form, and timing in relation to the uterine contraction. They could be due to umbilical cord compression. If they are uncomplicated, then let us remember the funda of 60. The drop should not be more than 60 beats per minute, and the duration should not be more than 60 seconds. The presence of shouldering in the variable deceleration is a good sign that the heart rate is actually responding. Initially, the umbilical vein gets occluded. There is an increase in the shoulder. There is a shoulder, and then it falls. Then again, when it recovers, there is again a peak, and then it comes to baseline. So presence of shouldering in variable deceleration is a good sign. However, in atypical variable decelerations, the duration may be more than 60 and drop may be more than 60 with no shouldering. Again, in decelerations, we can find that there will be variability also. Beat to beat variability will be there in the deceleration itself. If its presence is there, it is a good sign. But if there is no variability and the durations are more, again, this type of a deceleration is ominous. So there is, this is because of more prolonged and sustained compression, and this can also be there with uteroplacental insufficiency. So this is an early deceleration which mirrors the contraction. The late deceleration starts later after the peak of the contraction. When there is hypoxia, the chemoreceptors are stimulated. There is a deceleration, decrease in the heart rate because the fetus responds by decreasing the load on the heart. And again, there is time to recover. In variable deceleration, suppose this is the shoulder. When there is shouldering, that's a good, that's a not such an ominous deceleration, but the deceleration where variable deceleration, if instead of a V, it's a U kind of a shape, there is no variability here in the deceleration, that is again ominous. So we will be finding that what is the fetal response to hypoxic stress is always, whenever there is some stress, the baby responds by decelerating to decrease the myocardial workload. And of course, the loss of acceleration means baby doesn't want to spend more energy. Whenever there is continued stress, then we know that the sympathetic system will come into play and there'll be release of catecholamines. Now, because of the catecholamines, there can be increase in the heart rate. There'll be peripheral vasoconstriction to redistribute blood. And for metabolic conditions, there will be to increase the energy supply, there will be glycogenolysis in the fetal liver. So basically, if after a period of variable deceleration or atypical deceleration, if there is increase in the heart rate, we should not relax, because this could be the time that the baby is actually trying to compensate by release of catecholamines. So it is important to remember that getting a good or a higher baseline after initial insult may not be very comforting. Rather, we should be on the lookout that this could be the compensated response. And of course, if the stress of labor or the stress continues, the baby is going to go into the decompensated phase, with especially loss of variability means that the at the level of the autonomic nervous system, the responsiveness of both the systems is declining. So the loss of variability is a very important sign on the CTG graph. Again, progressive decrease in the heart rate, metabolic acidosis, and all the patterns we see that will be pre-terminal. We have to be very astute in understanding what is happening to the graph. A minute about the type of hypoxia which causes intrapartum. There are, depending upon the rapidity of onset, the intrapartum hypoxia is classified as acute hypoxia, subacute, gradually evolving in long-standing. Acute hypoxia and labor, we all know, and I think Dr. Asha will be taking it in bigger detail. But whenever intrapartum, we see that there is a drop of fetal heart rate which lasts longer, 3 minutes, and if it doesn't recover. we have to think of some acute cause, that is abruption, cord prolapse, or rupture. Here, the pH decreases at a very fast rate of more than 0.01 per minute. So we have to immediately manage. The 3, 6, 9, 12 rule actually just means that you can't keep waiting. You have to assess the patient. You have to take the graph again, see if the reassuring features, that means the baseline, it is not unstable baseline, and the beat to beat variability. If it is there, that is a reassuring feature. So in subacute hypoxia, we have to remember the importance is of the baseline. If the baseline is not stable and fetus spends less than 30 seconds on stable. See, when the fetus spends more time in a baseline which is stable, it means baby is more, well oxygenated. And deceleration means there is an insult. So if the insult is for longer and stability is for a shorter time, even if we don't remember these numbers, we can just look at the durations. The baseline is of a shorter duration, deceleration is a longer duration. It means there is some acute hypoxia. Because what we have to understand is this graph is showing us that the baby is going to get less time to have gas exchange and protect his brain from hypoxia. Again, gradually evolving hypoxia, the compensatory mechanisms are already there. So we have to basically, this is all being described so that we understand that what a deceleration implies. And with respect to a contraction, uterine contraction, what does it, what is the information it gives to us about the baby's well-being? I think that long-standing hypoxia, again, a baby who's got IUGR, antenatal insults, this already baby is in a going through chronic hypoxia. However, CTG is not the only tool where we'll be monitoring such babies. Of course, our clinical judgment and color Doppler, along with intrapartum monitoring, still we can deliver babies provided there is no loss of baseline variability. And sometimes, even compensated babies, they tolerate stress of natural labor. So unless we see that the deceleration is omnious and delivery is indicated. So our goal in CTG is basically to identify fetuses at risk of intrauterine hypoxia and prevent related complications like stillbirth and neurological damage. Other causes which can cause complications in interpreting CTG can be fever, can be prematurity, can be fetal cerebral hemorrhage, fetal anemia. We already described the head compression, which manifests as early deceleration. So we cannot, of course, my co-speakers are going to be defining these principles very elaborately, but I'll take a minute to explain Dr. C. Bravdo. Actually, this completes the whole interpretation of a CTG graph. The first and foremost is the mother. DR stands for the mother. So define the risk of the mother. Is she a high risk or a low risk? For example, if we are dealing with a PIH patient or a previous cesarean or a GDM or a asthmatic or whatever. So the maternal profile is the first thing which you have to consider. Second, we are going to deal with intrapartum. So we have to look at the contractions. Many times the CTG, the contractions probe is not put, the second transducer is not put. So we have to improve and rectify our practice that this probe to record the contractions is very, very important, and to set the zero so that we are able to decipher is there any contractions or not. Then comes the first thing, that is the baseline rate. The defined acceptable normal range is 110 to 160. But again, as I said, the gestational age is very important. If a preterm baby or maybe 36 weeks, the heart rate is 110, it's not normal. Or when the gestational age is less, the heart rate should be on the higher side. If the gestational age is more, for example, a 41 weeker, we do the basic CTG and the heart rate is coming 160. Should we think that it is normal? No, I don't think so, because it cannot be that a post-term baby is having such a high rate. So we have to think that maybe this baby is already in the compensated phase where the catecholamines are out and the tachycardia is there. Not tachycardia, obviously, but on the higher side. Then the next thing, as I said, the variability, the bandwidth, the interplay of the sympathetic and the parasympathetic. So if the bandwidth is between 5 to 25, we know this is a reactive heart of the baby. Whenever there is decreased variability, it means that the baby is trying to compensate, the baby is not good. Accelerations, we are all very familiar. We are always looking for these pahad. My staff also will tell me, Dr. Mitra, theek nahi hai, isme pahad hi nahi aaye koi bhi. So accelerations are very comforting. And the trick is to understand the decelerations. So the cornerstone and the most important thing that we have to remember, every deceleration means that the baby is trying to compensate. Now we have to analyze why this baby is compensating, how is it related to the contraction, and of course the overall assessment. So this is a normal CTG where the baseline is good, there's a reactive heart, and there is good variability. In this graph, the variability is good. Here the variability is not there. Beat to beat variability is not there. But is this baby compromised? No. As I said earlier, a sleeping baby where it is period of quiescence, deep sleep, we can get a graph like this where there is no acceleration and not much of variability, but the baseline is stable. The word here is stable. So here again, if we are in doubt, we can give a stimulus of a vibratory mode and then look for the CTG. So never just make decision on single CTG. When in doubt, don't hesitate to do it again. Again, this is a case of increased beat to beat variability. Especially this can be seen in cases when patients are pushing. So there is more than 25 beats per minute variability. And this means that this baby is going to go into hypoxia because of the increased, that we need to improve the oxygenation. Now, sinusoidal rhythm and pseudosinusoidal rhythm, we all know whenever there is fetal anemia or fetal hemorrhage, we get this sawtooth type of graph or sine curve. So we all have to, single graph will never give us the correct diagnosis. We have to see the patient in totality. So I have already mentioned what are the abnormalities: the absence of acceleration, increase in baseline, reduction in variability, and deceleration from V to U. So if it is a V deceleration and becomes U, means the duration of deceleration is prolonged. Again, this implies that there is hypoxic stress on the baby, and the baby's heart rate is taking time to recover. Again, this is a normal CTG and interpretation. I think, Dr. Sureka, can you please tell me how much time is left?
I don't know. Can we finish in the next 5 minutes?
Yeah, I will. That's why I asked, because I don't want to do repetition. So this graph is totally normal. At the single look, we can see accelerations and the variability and a stable baseline. So this is normal. See, whenever we are looking at a graph, we should see, is it normal or is it pathological? If it is normal, then very good. If it is not normal, it can either be pathological. So in a pathological CTG, there will be absent variability. There will be decelerations which are increasing in duration or recurrent and late. And the baseline, again, if the baseline is unstable, again, that goes into a pathological CTG. And bradycardia, a sinusoidal pattern. These are obvious findings. However, now this is again we have to look at the contractions, we have to look at the baseline. So these are good CTGs, normal CTGs. But this, we can see that there are so many decelerations every time. And this is a U deceleration and it is a delayed. So this is again, this is not a normal graph. This is a pathological CTG. Now suspicious is, see here, why are we calling suspicious is there is beat to beat variability even in the deceleration. So every point that we have mentioned, the baseline, the variability, the deceleration, or the acceleration, everything, and then its correlation with the contraction. These are all. So here I will not say it's pathological because still there is beat to beat variability. So this patient has to be assessed according to the progress of labor. Where is she? What will be the next course in the next half hour or 1 hour? So depending on the condition of the mother, the cervix, everything. So we have to take everything into consideration. Important thing is to, whenever we are looking at the CTG, look at the meconium, mothers, mnemonics, meconium, oxytocin, the temperature, hyperstimulation, epidural anesthesia, if it is being used, rate of progress and scar. Another mnemonic with respect to CTG and surveillance is spoiled. So whenever we find that there is hypoxia, fetus is going to suffer, stop the oxytocin, change the position, oxygenate before anesthesia, hydrate the patient, consider to lower the blood pressure, especially if maternal blood pressure is high, and tocolysis where there is hyperstimulation. So this is about lateral tilt. And I think I will now finish it off because Dr. Asha will be also taking. These are very nice graphs actually, but I don't want to overstep my time. So we all know that CTG does have its limitations because it reduces the mobility, and if we do not understand the graph properly, we may have increased intervention, or falsely, we may be under false security. So we have to understand the CTG graph in its totality. And I do hope that all these add-ons, the chorioamnionitis, the prematurity, and these things, and use of syntocinon has to be, integrated into the interpretation of a graph. And last but not the least, does this graph save us from litigation? I think before going into that, we have to be very, we have to understand that if we don't take these precautions, the paper speed should be 1 centimeter per minute. There should be time and date displayed, because what happens is that we don't start the CTG machine, our staff does it. So any rate and random, just starting it off, that is incorrect. If we really want to use this document to save us, to complete our notes, then make sure that the date and time and the data of the patient is entered. Only then this has got any relevance for saving us, because then we can justify our decisions. So I thought that this is really very important to mention here. The take-home messages are, of course, that whenever we see a reactive trace, we are very comforted. But whenever we see an abnormal trace, we have to assess it comprehensively and completely. And more important, the baseline and the variability and the decelerations and why they are happening. If we are able to understand, and I think if we have, understood what is happening and why it is happening, because now it is understanding of the CTG graph based on the physiology of the fetal heart, it becomes easier to take our decisions. And of course, obstetrician's decision always final. This is my patient yesterday, primary breech. She was for an elective cesarean at 39 weeks. At 36 weeks, and she came for her antenatal. She had no complaints, but I just saw this CTG. It's my practice to be safe and not charge her. When I saw an unexplained deceleration, I just put the probe and, I did the color Doppler, and I found that in the last checkup, everything was fine, but now she had no liquor, and the umbilical flow was compromised. The MCA was compromised. Her last checkup was 10 days ago and everything was fine. I mean, the CTG was fine. We don't do ultrasound or color Doppler every time. And so instead of waiting for 38 weeks, I just spoke to the mother. I said that, she's already 36 weeks. There's no point waiting. And there seems to be, because there is severe oligohydramnios, can I do section? And she agreed. So a male baby came out crying, although there was no liquor, not a single drop. So the obstetrician's sixth sense, I think, or the gut instinct, good luck, all is the culmination of years of experience, hard work, and good knowledge, and of course, God's grace. Thank you so much for having me on. I do hope
Thank you.
it makes some improvement in our understanding of CTG. Thank you.
Thank you, Dr. Mitra, for that very elaborate talk and real good understanding of physiology of the fetus and also the pathophysiology and interpretations. Now I invite our chairperson, Dr. Madhubala ma'am, for her comments. Madam, please unmute. Yes, ma'am.
As a chairperson, first of all, I congratulate Dr. Mitra. She elaborately, nicely present the CTG and details, and the mostly the patient is coming complicated cases, and then we are doing the CTG, and it helps lot of us for the saving the baby. But my suggestion to all of you that the CTG machine is in the government hospital is now available from 2 to 3 years only. I think that it should be available at the district and periphery also. So the patient get delivery load is at bed, and patient not get benefited with this machine. So I suggestion is to all of you that it should be recommended to, and mostly the deliveries occurs in the government institute. Private institute has very less load. So it should be available at every institute where the delivery load is more.
Yes, ma'am. Thank you so much. And it
Thank you,
is
Dr.
really important
Surekha.
that
Dr. Surekha, I just want to say one thing, that Dr. Madhubala, you are very right, that there is a lot of confusion in interpreting the CTG. This webinar today, designed by Dr. Surekha, Dr. Asha, and myself, is simply so that people can use CTG graph, understanding the graph in a very, very clear-cut way, and really use it for the benefit of everybody. Thank you, Dr. Surekha.
Can say the people like nursing staff and A&M कि मतलब मोटी-मोटी चीजें अपन उनको बता दें कि आपको ये इस ग्राफ में इतना ही देखना है, इससे ज्यादा नहीं देखना है, इससे ज्यादा गड़बड़ लगे तो आप हायर सेंटर भेज दें. तो अपन मोटी-मोटी पॉइंट पे अगर उनको बता देंगे ना मैडम, definitely it will benefit to the patient.
Yes, ma'am. Thank you very much. Any comments from Dr. Preeti?
आपने बोला कि पहाड़ नहीं, तो ये बहुत इम्पोर्टेंट है.
पहाड़ और वो सारे शब्द जरूर उनको, इनफैक्ट रिलेटिव्स को भी बहुत अच्छे से समझ में आ जाता है. ऊपर जा रहा है, नीचे जा रहा है, इतना भी उनको समझा दो तो they will really alert us. Dr. Preeti, any comments?
Yeah, I want to say that Dr. Mitra is really beautifully explained the CTG and its utility in very, very simple terms, and she has really cleared all the concepts, you know. Otherwise, you know, कोई भी CTG का नाम लेता है तो एक बार दिमाग में confusion आता है कि पता नहीं क्या निकलेगा. But you know, this way she has explained it so beautifully, and that it should become a normal tool for us. It actually will prevent fetuses being born with hypoxia and neurological defects, and it's the real need of India today.
Thank you very much, both the chairpersons.
I just want to share one thing. कि हर चीज personal experience से बहुत ज़्यादा you start believing in it. 30 years ago, or maybe 29 years ago, I was a VBAC, and we had CTG in Middle East. So I was monitoring the heart rate of my baby, continuous fetal monitoring that time. So I realized that it is really very useful. And when I came back to India, I thought we should start doing it. And I'm so happy that now everybody is trying to learn and use it in practice. And it is really very, helping for us to decide what is the condition of the baby.
Yes, ma'am. Thank you. And we move on to the next talk with our chairperson, Dr. B.S. Jodha and Dr. Mamta Sharma. Can we have their slide, please? The next chairpersons are Dr. Mamta Sharma and Dr. Jodha, sir. Dr. Jodha is from SN Medical College, Jodhpur, and he has so many awards. He's an endoscopy surgeon, sonographer, and ART specialist also. And presently, he is from Jodhpur, and we would like him to welcome our next speaker, Dr. Asha Jain. Dr. Jodha, sir, your.
Good afternoon, all. Thanks to organizer team, Dr. Mitra, Dr. Asa, Dr. Surekha, inviting me for this talk and chairing the sessions. And Dr. Asa she's MD, DNB, MNA, MNS, MBA. She's Director of SMS Hospitals, Raipur, Medical Director, CPRS, Raipur, elected member of CGMC 2024. She's Secretary, IMA, Raipur, President, ROGS, Raipur, Gynecological and Obstetrics Society, and President, Rotary Club of Raipur. We have heard in many webinars, Dr. Asa, and now you can proceed for your talk on the partogram.
Thank you, sir, for that kind introduction.
Let's keep to the time so that we can, have the panel also on time. Thank you very much.
So how many minutes do I have? You want me to finish by 5:30, right?
Yes, ma'am.
Okay. So I have something like 16 minutes, and Dr. Mitra has given such a scintillating lecture that it's going to be really hard to follow after that. But partograph was what I did my thesis on. My thesis was on paracervical block in labor, and I got the old Friedman's graph at that time, 1988, and plotted my cases on that. So it's a good refresher, and I found it useful then, and it is useful today. But the sad story is that today people don't actually use it. They use maybe some parts of it. They don't use the whole thing. When a survey was done, means 2 to 30% people were the only ones who were using a partograph for their deliveries. So if after listening to this, you can induct this into your protocol, it is a very important tool to keep obstetrics safe for the patient, for the baby, and for the obstetrician. Because if you have a complete record and you take a decision based on that record, which is signed by many people, there's hardly anyone who can lift a finger to you, because in spite of the best protocols, in spite of everything, CTG, Dopplers, unexpected things still happen. You cannot guarantee 100% normal delivery or healthy babies in 100% deliveries without any complication. So it is a very important tool to keep you safe. So with this, let us start. That's me. And why should you monitor? So this, I've already said that the intrapartum period is most dangerous and traumatic period. It's a time associated with high mortality and morbidity for both mother and child. Maternal and fetal monitoring are essential to pick up problems early, and so early timely intervention can be instituted. What are the complications of prolonged labor? Before this series, there has been a long series on PPH, and one of the leading causes of PPH is a prolonged labor. So maternal exhaustion, increased incidence of cesarean sections, birth canal injuries, risk of rupture uterus, and PPH. Also followed by puerperal sepsis and fetal distress, chorioamnionitis, neonatal sepsis, and intracranial hemorrhage in case a forceps is used when it should not have been used. Forceps is a very safe method to deliver a child, but the indications, the prerequisites have to be fulfilled. If not, it causes injury. So what is a partogram basically? It's a composite graphical record of progress of labor on a single sheet of paper. It has been tested extensively by WHO in 1994, and it can serve as an early warning system and assist in making decisions and interventions. It has been modified in 2018, and we will deal with all the partographs one by one. What are the advantages? You can see everything at a stretch. You can prevent prolonged labor because there's an alert line and then there is an action line. So you know that something is going wrong, you get alert, and then you can recognize CPD long before obstructed labor. You can allow time and discussion for augmentation, whether it is needed or not, and you can give personalized care depending on the graph. So there is an early recognition of fetal-maternal problems. It's highly effective in reducing complications from prolonged labor for the mother and for the newborn. It reduces the incidence of cesarean section and facilitates handover procedure. What is the disadvantage? It assumes that all women progress at the same rate. We all know that is not true. There are primies who will deliver in 4 hours, and there are multis who will take 12 hours. Clinical findings have subjective variations. There is a lack of knowledge about it. There's non-availability of printed partographs, as I had to do in my thesis time. It was a great problem. And then there is duplication of recording. So the first partograph was developed in 1954 by Emanuel Friedman, and it had cervical dilatation and fetal station against time. In the time of the time of onset of labor was based on the patient's subjective perception of her contractility, and plotting cervical dilatation against time yielded the typical sigmoid or S-shaped curve. And station against time gave rise to the hyperbolic curve, as you can see here. So this is the time, this is the cervical dilatation, and this is the fetal station. And you can see the station has to go down, it comes like this, and then you have the dilatation which goes up. So this is how it intersects, and this is the Friedman curve. What happens in a nullipara? As we all know, it will have a longer latent phase and a longer active phase. All the phases are longer in a nullipara compared to a multipara. Here you can see in a multiparous woman, the latent phase is quite long, but then suddenly once she starts dilating, she just proceeds fatafat and delivers. Whereas it takes much longer in a primary. From here, the difference is from 7 hours, and here it's 12 hours. In the textbook of Holland, it's written, the sun should not set twice on a woman in labor. And here you can see on an average, it's 12 to 13 hours for a primary and 6 to 7 hours for a multi. Then in 1972, the concept of an alert line and an action line was added, and normal labor is plotted on the left side. So if the alert line is crossed, it means there's something wrong. The alert line and the action line has a difference of 4 hours in between. The WHO partogram has been modified in the year 2000 to make it simpler and easier to use. The latent phase has been removed, and plotting on the partogram begins in the active phase when the cervix is 4 centimeter dilated. This has now been changed again. Initially, it started with 3 centimeters. Now the WHO changed it in the year 2000 to 4 centimeters. And now it has been changed to 5 centimeters. So this is a graph. You can see fetal heart rate, the liquor, molding, the station, the dilatation, contractions per minute. This is, everything has to be charted by somebody, and then it has to be signed. So another one, this is the alert line and this is the action line. And there's a difference of 4 blocks in between. So it is 4 hours away. You have 4 hours, but now I think in the recent change, these lines have been removed. So what are the stages of labor? The first stage, after the onset of labor pain, still full cervical dilatation. Primary 12 to 16, multi 6 to 8 hours. Second stage is from full dilatation to delivery. In primary, it is 1 to 2 hours, and in a multi average, half an hour. Third stage is complete expulsion of placenta and membranes, which is up to 30 minutes. That's it. You do not wait more than 30 minutes for third stage. So what are the components? There's maternal information, the basic information, the name, age, ID, etc. Then fetal heart rate, character of liquor, the molding, labor progress, dilatation, descent, uterine contraction, any medicine that has been given, and then the maternal well-being, BP pulse, temperature, urine, albumin, glucose, acetone. So everything is here on a single piece of paper. So the part one is patient identification, where you have the name, gravida, para, hospital number, date and time of admission, and the time that she ruptures her membranes. Part two is the fetal condition, heart rate, liquor, and molding in the skull bones. Then the fetal heart rate chart, where you chart it as dots on the graph, time against the heart rate, caput and molding, whether it is present or not. Then the progress of labor is the cervical dilatation, descent of the fetal head, uterine contractions, and fetal position. Head station 0 up to -3 and then +3. So, and the position of the sutures. You can mark it here where it is and what is the level. So it has to come from above to below. This is how it has to come. Uterine contractions. This has been changed now because this is more of a diagnosis by the mother. Uterine contractions per 10 minutes. If it is less than 20 seconds, it's weak. 20 to 40 seconds, it's moderate, and more than 40 seconds, it's good. So this is how you have to chart it against time. Then the maternal condition. Pulse every 30 minutes, blood pressure every 4 hours, temperature every 2 hours, urine volume, analysis of protein and acetone every time that the urine is passed. Again, oxytocin, how much has been given, what are the drops per minute, drugs, anything that you add, and IV fluid, which fluid and in which amount. And this is the image. So how are you going to manage labor using the partogram? One of the main functions of the partogram is to detect early deviation from normal progress of labor. That is most important. If there is arrest at any stage, there should be an alert and then an action. Pattern of abnormal progress of labor, disorders of first stage of labor, prolonged latent phase, disorders of active phase, and arrested active phase. It is prolonged when the duration exceeds 20 hours in a primary and 14 hours in a multi. According to WHO partogram, a prolonged latent phase is cervix is not dilated beyond 4 centimeters after 8 hours from admission. So 4 hours के 4 centimeter के आगे देखना है. Expectant awaiting active labor provided no indication for delivery. So you can just give simple analgesics and reassurance. Active phase, if delivery is indicated, induction and augmentation of labor, early ARM, increased risk of prolonged labor with PPROM, risk of intrauterine infection and neonatal sepsis, risk of cesarean sections 10 times if you do an early ARM. So you need to really be careful whether you're really going to do it or not. Prolonged active phase, plotting of cervical dilatation will normally remain on the left of the alert line. If it moves to the right of the alert line, it warns that labor may be prolonged. Happens if the rate of cervical dilatation and active phase of labor is less than 1 centimeter per hour within 4 hours. At the action line, the woman must be carefully reassessed for why labor is not progressing and a decision made for further management. So basically, it's the same thing that you need to plot it. If you examine and plot, if there is a deviation, then you have to take action. So this is the alert line, and you can see this, it's going, the cervix is almost at the same station. So this is where it has crossed the action line and action has to be taken. Secondary arrest of cervical dilatation, when cervical dilatation commences normally but stops or slows significantly for 2 hours prior to full dilatation, or if the head does not descend. If the head does not descend, these are secondary arrest. So this is the cervix, this is the fetal heart, and this is the descent of the fetal head. 3, 3, 3. It hasn't gone down. And the cervical dilatation from 4 to 5, and then it has stuck at 5 and it has crossed the action line. And you have to do a cesarean section. And here, when a cesarean was done, it was 4.6 kg baby. So we know it was a CPD that has caused this problem. So when there is a prolonged active phase, how are you going to manage it? Evaluate the cause. If there is hypotonia, augment it. If there is normal progress, she'll have a normal delivery. If there is no progress, there is arrest, then she proceeds to LSCS. If there is hypertonia and you find out that it's an augmented case, then reduce the dose. Then see if she has an arrest or progresses. Or if there is CPD, then you proceed for an LSCS. So basically, it will help you to take an earlier decision for LSCS, and you will not have a impacted head in your pelvis, which will be difficult to take out in labor. Management, diagnose and evaluate the cause, CPD or no CPD. If there is no CPD, then you assess uterine activity. If it is optimal and still the case is not progressing, do a cesarean. If it is suboptimal, augment. Either she will progress to normal labor. If there is no response, she'll have a cesarean section. Now the WHO modified partograph. This is one slide that you should be reading. What are the similarities with the previous partograph? Graphical representation of progress of labor in terms of women's cervical dilatation and descent of the fetal presenting part against time. This is the same. Formal, regular recording of important clinical parameters describing the well-being of the woman and baby. These remain as per the past partograph. The difference is active phase is defined as starting from 4 centimeters of cervical dilatation. In the first one, now it is 5 centimeters. They had a fixed 1 centimeter per hour alert line and action line. And here evidence-based time limits of each centimeter of cervical dilatation. There is no second stage section in the old partograph. There is intensified monitoring in second stage in the recent partograph. No recording of supportive care interventions in the past partograph. Now there is explicit recording of labor companionship, pain relief, oral fluid intake, and posture. This has been added in the partograph. The past partograph records strength, duration, and frequency of uterine contractions. This records only duration and frequency, not the strength. No explicit requirement to respond to deviations from expected observations of any labor parameter other than cervical dilatation, alert, and action lines. Here, it requires deviations to be highlighted and the corresponding response to be recorded by the provider. So the partograph also has to record who was there, what other medicine has been given, what was the posture, and what you did to relieve it. So this is the part that has changed.
For wrap up, ma'am.
Yes, please. These are the last few slides. So a companion, pain relief, oral fluid, posture. These are added. Then you have, this is what was previously there. This is also what was previously there. This is added. The assessment and the plan of action and the signature. This has been added. Shared decision making, the assessment, what is the plan, and what is the plan that you have taken for this delivery. So what is the conclusion? It's a simple, clear, easy to use, cost-effective tool for monitoring of labor and decision making. It significantly improves perinatal outcomes. It can be effectively used in facilities at any level of care. Strictly following the rules for partogram use ensured its effectiveness. It can be used in any labor in high risk and low risk women. It is a documented evidence for medical legal purposes and educational value for all grades of staff. As Mitra Madam said, Pahad. So this is what everybody can learn from it. Thank you. And I request your support for my candidature. Thank you.
Thank you very much, Dr. Asha. That was really very crisp and very clear. And of course, thank you for staying to the time also and covering everything elaborately. I think hats off to you for such a beautiful lecture, and I request Dr. Jodha for his comments.
Dr. Asa has taken the partogram to the labor room and making it simple for all the people who are working day and night, shifting their charges from one residence to others. So keeping all the things in a record will be fruitful for all of us, because the consultants and faculty members are attending, and the next day they can assess what was with that particular patient, what made her to undergo cesarean sections. So they can be taken care by the partogram. If it is practiced very well, then it is very good tool, and also helping in especially the medical legal era, where it be of help for each and every obstetricians, where things can be explained that these things are going very well, and this has happened because of the obstetrics. Sometimes it is of very unpredictable things, and that can happen at any time. But keeping these things in mind and keeping these records properly will help to each and every obstetrician. And I thanks that Dr. Asa has taken it to the very height, and so many people joining, at least more than 250 persons were listening, and they will make it the note of it and will be benefited by these. Thank you very much, Dr. Asa.
Thank you very much, Dr. Jodha. And I would just like to inform the audience that being in a medical college, I have seen many a time the residents used to retrospectively plot on the photograph. The patient used to deliver and then they used to plot, because they used to be afraid tomorrow morning the professor will come and look at the photograph. So at MGIMS Sevagram, we did a multi-centric, study on an electronic photograph. Actually, we developed the electronic photograph along with Jeevdaya Foundation. And then in this electronic photograph, we have to plot prospectively. Actually, the computer will not allow you to do a retrospective plotting. So everything would be on the screen, and the head of department or the unit in charge will be able to see on a bigger monitor all the patients who are laboring in the labor ward. So that's a beauty of an electronic photograph, and the professor can see from his or own chamber and monitor. So this is now the beauty. It is coming up on the Android phones also, on the tablets also, where now the photograph is become digital. So that is now what we are moving towards. And thank you very much, Dr. Asha and Dr. Jodha, sir, for beautifully coming up with the advantages and clarifying the photograph so well. So now we move on to the panel, and Dr. Asha, I would just like to invite you to to introduce the panelists, but not myself. I've already been introduced.
So,
ma'am, just before that, we have a small 1-minute video break.
Yes, Deepika.
Jagsonpal Pharmaceuticals Ltd proudly presents PRORETRO, micronized Dydrogesterone tablet 10 mg. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for PRORETRO.
My teammate from sales, Mr. Vijay Kumar, is here from Naari division.
Good evening, doctors. From Naari division of Jagsonpal, myself, Vijay Kumar, Zonal Sales Manager North. and we look forward to your support for the PRORETRO. With this webinar, we have the pleasure to share with you the development which Jagsonpal has made in the recent times with active pharmaceutical ingredient of that dydrogesterone used in PRORETRO, that is 10 milligram tablet that we have. After years of the indigenous research and development, Jagsonpal is proud to have made in India self-reliant Atmanirbhar Bharat for the critical API of dydrogesterone, reducing the cost of the patients remarkably. Cost just 50 rupees per tablet that we have kept. Made in India PRORETRO, micronized dydrogesterone 10 milligram tablet are assisting motherhood, delivering happiness. Thank you. And one more brand that we have for the management of the fibroids, we present Fibrostone, that is Fibrostone 25 milligram that we have, Mifepristone 25 milligram, Liquacin 4 25, very feel that, and we look forward to your presence in the future program as always.
Thank you.
It's my pleasure to invite my co-convener, Dr. Surekha Taide, as the moderator for this session. Next, please. And our esteemed panelists, Dr. Taruchaya Bansal, who's the Secretary of Jaipur Obstetric Gynec Society, Dr. Prakash Jain, who's the Secretary of Udaipur Obstetric Gynec Society, Dr. Raksha Sharma, Secretary, Kota Obstetric Gynec Society, Dr. Akriti Jha was supposed to join us from Secretary Alwar, but I think she's not joining.
Excellent.
Dr. Manju Singh, Secretary, Bharatpur Gynec Society, Dr. Prerna Rathor, Secretary, Hanumangarh Obstetric Gynec Society, Dr. Ajay Sharma, Secretary, Ajmer Gynec Society, and Dr. Kamla Verma ma'am, Secretary, Bikaner Obstetric Gynec Society. So everybody just gear up for another scintillating session where questions are going to be bombarded by Dr. Surekha Taide to our esteemed panelists, and then get ready for the quiz. So welcome, Dr. Surekha. Over to you.
Thank you, Dr. Asha, and our esteemed panelists who have joined from all over Rajasthan here. And I would like to go ahead with the panel. So we are here now for the panel here, and definitely it is going to be a scintillating panel with a lot of cases. And I bring greetings from my medical college, which is Jawaharlal Nehru Medical College. And we have a wonderful virtual simulation lab. As you can see here, we are teaching our students and our nurses on mannequins. And it's a beautiful medical college. Myself, I'm presenting myself as your candidate for Clinical Research Committee, as a guide, a teacher, a researcher from last 20 years. These are our esteemed panelists who have already been introduced. Now we know that CTG is a critical tool for labor monitoring. Apart from, both the tools are so important, the partogram and CTG, and especially CTG is used for fetal surveillance. And definitely we would like to reduce the birth asphyxia, but on the other hand, we would like to, stop or curb the rising cesarean section rate. I'm not going to go to the basics again because this has already been taken in detail by Dr. Mitra. However, you just have to look at these boxes and remember that 2 boxes are 20 beats, 1 box is 10 beats per minute. And of course, this is the heart rate which is being plotted here. Paper settings, I'm again reiterating that the paper speed has to be 1 centimeter per minute, sensitivity display 20 beats per minute, and the FHR display as per NICE is 50 to 200 beats per minute. This C brevido has already been described. I'm not going to go into the details of it. Already this has been described. So I will, go to the first case because we don't want to spend too much time in what has already been described. So this first case, I would like my panelists, esteemed panelists, Dr. Taruchaya, to kindly describe this CTG for the benefit of our audience.
Hi, everyone.
Thanks, Dr. Mitra and Dr. Asha. You have explained everything very nicely. In this case, I have to discuss.
Yes, please describe the CTG first, and then we will go to the case. What all you are looking at?
We are looking at normal baseline. We are looking at accelerations. We are looking at decelerations. In this CTG, there is tachycardia. And there is normal variability, but tachycardia is there with little bit acceleration. It looks like only baseline tachycardia CTG to me.
Yes, ma'am. So we go ahead and I will let you know the case. So this patient is a 28-year-old. She the second gravida, previous vaginal delivery, and at 38 weeks of gestation. She was complaining of fever since 2 days. And when she came to us, she also complained of decreased fetal movement since 1 day. And this is the CTG which was taken up. Now, what is our this CTG, as you have rightly said, is showing tachycardia, normal variability, few accelerations are also seen. So this patient with fever and this kind of CTG, how would you proceed further?
See, she is 38 weeks, almost fully mature. First normal delivery. And the important thing which is disturbing is fever for last 2 days. Because of fever, there is tachycardia. We don't know exactly how much is the grade of the fever. For 1 degree rise of fever, we increase the heart rate by 10. That is maternal. With the maternal heart rate, there is obviously slight increase in fetal tachycardia also. So in this case, we have to find out, we can go for normal sonography also, because there is a complaint of decreased fetal movements. We don't know movements are because of dehydration or because of decreased liquor or something else. There is no history of fever in this case. We don't know about it. So we should take the proper history in details. And then we have to find out diagnosis of fever, why the fever is there. Maybe because of the COVID era, we have to find out that COVID conditions also, and differential diagnosis, we could CBC and CRP and other investigations. And if in sonography find the liquor is adequate, maybe because of dehydration, she is having lesser fetal movements, we have to manage properly and give her some fluids or oral fluids if she is able to take, and paracetamol SOS, she'll be fine. We can repeat CTG in case we need.
Absolutely wonderful, Dr. Taruchaya. And to the point, you have very nicely explained. Yes, we are having a CTG in front of us, but our aim as an obstetrician should be look at the patient holistically. The patient has come to you with fever. So that is what we need to concentrate upon and find out why there is fever, take the history, what kind of fever it is, what is the duration of the fever, and then definitely we like to do the lab investigations, the complete blood count. And then in our setup, we also look for malaria. Nowadays, dengue is also so common. So all those things you have to first investigate, find out the cause, urine culture, the vaginal swab, is she is having PROM. So doing the per speculum examination, finding out of any genital infection. Cause of the fever is what you have to find out and treat the fever. So what we want to give the message is treat the condition and not the CTG. You would also have to do the ultrasound and the Doppler and to find out why there is a decreased fetal movements. Is the Doppler abnormal? Is there hypoxia? Why? What is the reason? Or as rightly said, it could be just because of the fever and some hypoglycemia. Because of that, there is decreased fetal movement. So treat the patient accordingly, manage the fever of the patient, and definitely if you repeat the CTG, you may find that now the patient has a reassuring side CTG. So very rightly said, and the take-home message for the audience is that even you look holistically for the patient. So not only the trace, but the condition and the case is also very, very important. So rightly said and very well done, ma'am. So we have the second case for Dr. Ajay Sharma. We would like him to read the CTG for the audience, please.
Yeah, hello.
Yes, Dr. Ajay.
Good evening to all of the panelists and eminent speakers present here. As I can seeing the CTG from your side on my phone, there is very less beat to beat variability in this slide, and very few decelerations I can see. Amplitude is also high. So maybe the preterm patient or having fever also.
I will go to that, doctor. I'll just tell you the case also.
Tachycardia is also there, ma'am. Tachycardia is also there in
So
in,
we will
in
go
this slide.
according to Dr. C. Bravado, that acronym is there. And as rightly said, tachycardia is there, the rising baseline and the reduced variability. Few
decelerations are there.
And there are contractions.
Yes.
So we go on to the case. This is a third gravida, one live baby, one abortion, 28 years old, one previous vaginal delivery, and she is a 32-weeker PROM. So now with this CTG, she is also having fever and foul-smelling vaginal discharge. What do you think we should do when the patient is having temperature of 101 and foul-smelling vaginal discharge? CTG, as rightly said, has tachycardia, reduced variability, and few deceleration. What would be your next step for this patient?
Ma'am, patient is preterm, as you told, that 32 week of gestation is only there. PROM may be a case of chorioamnitis also. How long since the membrane is absent, we should find out. And we should treat the fever. But in the CTG, I can see that good uterine contractions are also there, and reduced beat to beat variability is very less. So I would like to prefer for normal labor in this case, and would go with expectant management, and would wait for normal delivery, and would like to call for pediatrician at the time of delivery in the preterm history of the patient.
Yes, definitely.
Dr. Surekha, can I ask one question?
Yeah.
Can you go? I just wanted to know, why are we having two graphs like in this? Is there some?
Yeah, this is the maternal pulse which is being recorded here. Very rightly pointed out, ma'am. But that sometimes we may get a maternal recording also. So we have to be very careful with these kinds of recordings. Very nicely and very nice, rightly pointed out, very observant of you, Dr. Mitra, and very nicely pointed out. And as Dr. Ajay has said, that we, as this is a 32-weeker with PRM, and the discharge is all foul smelling. So we do need to assess the general condition of the patient. What is the general condition? Is there a fever? Is there any anemia? And that is the thing we need to optimize first. And of course, we need to find out whether there is an associated chorioamnitis in this patient. As far as the infection screen is so important, before starting any antibiotic, we'd like to take the vaginal swab, the cervical swab. We'd like to do the complete blood count and find out if there is a possibility of a chorioamnitis. Is the patient having, the obstetric examination is also important. What is the presentation? How does she have any contraction? Is the patient in labor? So if she is in labor, already the progress of the labor, what is the color of the liquor, all that, the fetal condition has to be found out. What is the estimated fetal weight? You would like to do an ultrasound and Doppler. What about steroids, sir? This is a 32-weeker. You would like to give steroid in this patient, and with possibility of
in the background of infection, I would not like to cover for steroid.
Okay. There are two schools of thought regarding this. In fact, in an obstetric sepsis, we usually would like to give few doses of your steroid. So as far as the guidelines are concerned, the doses of steroid which we are given is for fetal lung maturity. So that would not be a problem. And in fact, it would assist for the lung maturity. So that's not a problem actually to give the dose of steroid what we prescribe for lung maturity. So as rightly said, we would like to see the case holistically. And if there is a possibility of infection, we would like to start the IV antibiotic for this. Yes. And of course, when we do a pervaginal examination, already if the patient is in labor and in the background of chorioamnionitis, you would like to deliver this patient. If the patient is not in labor, and then if you want to terminate and you want to take a cesarean decision for cesarean section, then again you have to remember that you have to be very careful when you do a cesarean section for this patient in the background of sepsis. So that these are the things you have to weigh according to the patient's abdominal findings and vaginal findings, and accordingly you would like to take and this patient actually was in labor, and she progressed spontaneously and delivered with the low Apgar score. However, because there was a background of sepsis, and thus very rightly said, you said that you need to have a experienced pediatrician who would take care of this baby, who is not only preterm, but there is a infection. So thank you very much for those beautiful comments and very nice take-home messages for our audience. This case is for Dr. Akriti. She has not joined. So we want Dr. Taruchaya to kindly read this CTG.
In this is a CTG where what I can see is the baseline is above 170 beat per minute. So the patient's, there is tachycardia along with baseline is higher, and accelerations are very sluggish with few decelerations, but I can see few contractions also along with, and with the contractions, I'm finding that deceleration is little delayed, and another contraction which is also little late, but deceleration is very deep and more delayed. So this is not a normal deceleration in my opinion.
Okay, so let us look at the case, ma'am. She is a 6th gravida, 4 abortions, one 36-year-old, previous one vaginal delivery. Now she's 37 weeks. Is already a known case of APLA. She is on low molecular weight heparin. She took a dose of 40 milligram at 9 a.m. She reported to you at 7 p.m. with pain. This pain was since 2 p.m., but she reported after 5 years of pain with you. Now, this is the scenario in front of you, who is a case of APLA and who is having these kind of, decelerations. Now, how would you proceed?
As you earlier also said, KV has to have a holistic approach. In this case also we'll have, because she is a case of RPL, 4 abortions, although 1 normal delivery, and she has attained 37 weeks of gestation, full term. And she is on Tlaxine 40 milligram, which she took at 9 a.m. in the morning. And she started her pain approximately 5 p.m. when she came to the hospital at 7 p.m. 2 hours of already there. CTG is saying that there is baseline is more, 170 minutes, 170 per minute beats RAS ka. And then reduced variability and decelerations are also there. It looks like a pathological CTG to me. And we can, although we can go for some few investigations like sonography and all, but since what are the PV findings, we have to just rule out. If the PV findings are good dilatation and good effacement, and if we feel within 1/2 an hour or so the baby will deliver, then it's okay, we can go for normal vaginal delivery. If we see this is going to delay, then for betterment of baby, we have to go for cesarean section.
Absolutely, madam. Very rightly said. This is not a good strategy. This is a pathological strategy. This patient needs termination, and we would really like to do the pervaginal examination and find out if she's in labor or not. But if she does need these kind of decelerations and the variability is so poor, and as you can see, the contractions are not there. So probably without any contraction, if this kind of CTG is there, then the baby is already hypoxic. My question to you is, with the low molecular weight heparin given at 9 a.m., what alert and what kind of precautions will you take for the patient if you want to go for cesarean section?
See, this is low molecular weight heparin. This we can go for cesarean section. There's no harm.
Yeah. So already patient has come to you after almost 10 hours. And we have seen so many cases we have done with LOMO, and there is actually no problem. We have to just be ready with the blood and blood products. You may need fresh frozen plasma. However, you have to be ready to tackle any bleeding if it is there. But we have seen so many times that usually there is no problem if the patient has taken LMWH before 10 hours. So not a problem at all. However, we need
to take care, proper care. Post PPH, we have to see to rule out that, and we have to take care of that.
Yes, the team has
Can
to
I
be
add
ready.
something, Dr. Sureka?
Yeah.
I think in this patient, very nice cases are being discussed. Congratulations, all the people participating. In this case, I think before surgery, it will be, although we know that LMWH does not cause much problem in, hemorrhage, but we should get the coagulation profile, PT, APTT, and
yes,
INR,
definitely,
and platelet counts, and proceed without, fear. But at least that much we should have done.
Yeah. Definitely, I agree with you totally that the coagulation profile. We all our patients who come to us, we do a fresh CBC, because most of the time they come to us with CBC, but the CBC is older. And so we would like to know what is the fresh hemoglobin, the coagulation profile, and rightly said the INR of the patient, so that we are ready with the blood and blood product before we embark on a cesarean section or even a vaginal delivery. We really need to know what is a coagulation. Thank you very much for pointing that out for us. And we do have to remember that this kind of evolving hypoxia is actually telling us about the stress which the patient, the baby, is undergoing. So the deceleration, even the loss of accelerations, the exaggerated response, like the decelerations becoming wider and deeper, these are the attempts of the fetus to redistribution the blood to the vital organs. So this is the first sign, is a rise in baseline. Then further redistribution, there will be a reduced baseline variability, and terminally there will be an unstable or progressive decline in the baseline, a sort of a step ladder pattern to death, and that has to be recognized quite early, and the action has to be taken so that we can save the baby. Thank you very much. And of course, the traces which warranty
the tachycardia is because of the catecholamines. Yes.
Decelerations without the baseline variability, baseline tachycardia without decelerations, prolonged decelerations more than 3 minutes, or a sinusoidal pattern. These are the patterns which warrant actually a decision for termination of the baby. So now this is for Dr. Prakash Jain. Sir is here. Can we see him? If not, I would like Dr. Mitra to kindly read the CTG for us.
Okay, so of course, the first condition, the patient's risk, Dr. Sureka will be telling us. And then when we look at it as the glance, we can see that there are uterine contractions which are there. So maybe the patient is in labor. Now, looking at the first thing is the baseline. So whenever we have to look at the baseline, we should have at least a 10-minute segment. And in that, if 2-minute area, that would take as baseline. Here if we see, we can see apparently this is the baseline. Here there is a dip again. So we have to see whether the baseline is stable or not. Whenever we see a baseline, if the segment is less than 2 minutes, that means we have to consider this as an unstable baseline. So definitely at a single glance, we are not getting a very good segment of a stable baseline. So that is one thing we should keep in mind, that whatever is the baseline, it's not a very stable baseline because it is varying. Then we are seeing deceleration. We are not seeing the, very prominent. There is beat to beat variability. That is one thing which is a little reassuring. But we are seeing there are decelerations and there is decline in the baseline. So this is not a very comforting, picture. So
yeah, this is a prolonged deceleration, as you have been seeing, and it is more than 8 minutes.
Yeah,
you can see that it's a prolonged deceleration.
And it is coming down. So
it's
what
coming
in this,
down.
Another thing is that, okay, it is 41 weeks induced.
Yeah, let me read out for the audience.
Yeah. Okay.
She's a second gravida, P1 and 41 weeker, and she has been induced with oxytocin. And this is the CTG which we are seeing now. What would be your management for this patient?
So quite obviously, we are finding that the baseline is coming down and there is deceleration and there are contractions. So the first thing would be to get the stress of this oxytocin off. Because once that is off and the patient is rehydrated, then we would like to again review the condition of the mother, the cervix and the baby. So if the mother is stable, no problem with the blood pressure or anything, and the cervix, let us look at the cervix, because our management is going to depend upon the progress of labor. And also, once the stress is off, the patient, the syntocin on the tachysystole is taken care of, it stopped, in fact, and patient is hydrated, we can again see the CTG. If we get a stable baseline, variability is there, that means that the baby is oxygenated and the deceleration was only because of oxytocin. However, because it is a 41-weeker, we have to take a decision according to how are we going to deliver the patient.
Yes, Dr. Mitra, rightly said. First of all, take care of the stress. Is it because of the oxytocin that the baseline has come so low and there's a prolonged deceleration? You have to see to that. You may have to even give a uterine relaxant to, reduce the contraction which are coming so frequently. As you can see, the contractions are quite frequent. And rightly says, assess the cervix. And if there is an accident like a cord prolapse, you will have to definitely go and do an immediate delivery of the patient. And depending on the stage of the labor, you would have to inform the pediatrician and the anesthetist. Actually, this patient settled down after stopping the syntocin, and you could deliver this patient vaginally because she was already in the later stage of labor. So that's an important message, that anything which is causing this kind of stretch, first you have to stop it and take care of it and review it. And depending on the stage of labor, you would like to deliver the patient, and depending on what stage of labor she is. So as previously also we have in the talk, it was very much highlighted regarding the 3-minute rule. So from 0 to 3 minutes, if there is a deceleration, then you have to raise an alarm. The doctor has to come and assess, the team has to come and see what is the cause. From 3 to 6 minutes, you try to attempt to diagnose the cause. If there is some cause, like, if there is a oxytocin, or if you think there is an abruption or something, then you need to take care of that cause, safely deliver the patient with the fastest route. And if iatrogenic cause is there, then you immediately need to correct it. Avoid the supine position, take the patient to left lateral, stop the oxytocin, start the IV fluids, and if required, administer the tocolytics. So that is what is the 3-minute rule. So 3, 6, 9, 12, that is how it goes. And the baby has to be out if there is any accidental cause like a cord prolapse or anything which you could diagnose.
So there was one question in the chat box, Dr. Sureka.
Which will take later? Which will take
No, I think side by side kar do. So then we can
नहीं, वो मुझे दिख नहीं रहा है, तो मैं
I will tell you. It is, what are the tocolytics available? That's what I'm saying.
Terbutaline you can give, whatever you want.
Terbutaline is not available.
Whatever is available and comfortable in your own setup,
Udaipur is the only injectable available.
Yeah.
Even Ritodrine is not available, but yeah.
So these are the causes of acute hypoxia. It could be a cord prolapse. It could be a retroplacental bleed. It could be even a scar dehiscence if it's a previous scar patient. It could be an acute hypotension. So you need to diagnose and correct it, and then again review the CTG, and accordingly you should go ahead. So this question is for Dr. Manju now. Madam, I request you to kindly read this CTG for our audience.
Okay, thank you. Thank you, Sureka ma'am. So, according to this CTG, I will go by the acronym Dr. C. Bragado. First of all, coming to the DR, defining the risk of the patient, I would like to take a clinical history and examine the patient and categorize the patient as low risk or high risk in terms of being a preterm or a post-term or a PROM or a oligohydramnios or an IUGR or a PIH patient. Or
definitely, ma'am.
Or a
so that's
like that. So
yes.
I categorize the patient first into a low risk or a high risk. I will like to corroborate this with my CTG tracing. So coming to the C, I am not finding any contractions on the tracing. So the patient is not in labor. Then coming to my baseline fetal heart rate, it is about, I think, it's about 150. So it is almost normal baseline fetal heart rate. Then coming to the variability. In the latest tracings, I am finding a reduced variability, which is like a ominous sign for me. Then coming to the accelerations in the initial tracings are present, 1, 2, 3 acceleration. There are like 1 deceleration, but it is there, it's going, no deceleration. And last, then after all, I will give the overall opinion.
Yes, ma'am. Before that, I'll let you know the history of this patient, ma'am, so that you can speak on it.
Okay.
So this patient actually is a 30-weeker IVF pregnancy, and she had severe preeclampsia. And for that, she was given magnesium sulfate, and also she was given steroid. And this is the CTG we find. So what your management now?
Okay, ma'am. So this decreased variability can be explained firstly due to prematurity, because it's just 30 weeks. Then because of the steroids which we are giving, maybe the decreased variability is due to that, or even due to magnesium sulfate. The decreased variability may be due to magnesium sulfate also. So I would like to categorize this patient in a suspicious high risk pregnancy, in which the CTG tracings are coming in a suspicious category, or the category 2, or a non-reassuring CTG.
Yes, ma'am. And of course, your management will be, what would it go further as a management?
It's a severe preeclampsia. The maturity is just 30 weeks. We have given the steroids. We'll go for a repeat CTG. We'll keep the patient admitted. We'll use the magnesium sulfate. We'll give the neuroprotection also and prevent the eclamptic seizures also. And wait and watch how the BP is being managed by an antihypertensive. And accordingly, if the lung maturity is achieved, we'll get the patient delivered.
Yes, ma'am. Definitely, it is not the CTG, but it should be the patient we have to see holistically. Yes, there is some reason which we could find out for the reduced variability, and that is the drugs which we have given, which is the magnesium sulfate and the steroid. So we do not have to panic if we just see a reduced variability. We find the cause, and the cause is already there. So for this patient being a severe preeclampsia, we would, do the lab testing accordingly. We continue the management. We will treat the patient for her preeclampsia with antihypertensive, and according to how the patient responds and how the continued monitoring, we will take the decision for either we want to continue the pregnancy or we want to terminate it. So that would depend on our further evaluation of the patient. That the simple one CTG will not dictate that we want to go for a cesarean section or something. We just need to, evaluate. You need to find out the cause. You treat the cause, and she being just a 30-weeker, we would of course like to, pull the patient till at least 34 weeks, depending on the fetal and the maternal condition, and accordingly we would like to manage. So thank you very much for that wonderful and complete, solution which you found. Yes, this patient. Dr. Raksha, this patient is for you, and this is the CTG we would like you to read for our audience.
First of all, I am very thankful to Surekha ma'am and Asha ma'am for inviting me to this panel. And without further ado, I would like to read out the CTG. Here, baseline seems to be 150 beats per minute, and variability is less than 5 beats per minute. So it's a non-reassuring feature. Then there are no accelerations. Deceleration is there, and it is wider deceleration. It is indicating hypoxia. Contractions are there, but mild.
Yes, ma'am.
And I would
just like to tell you the history.
24-year-old
primary gravida. She's 36 weeks, and she came with a tense abdomen with a blood pressure of 140/100 and this kind of CTG. Now, what would you suspect?
Now, on the background of this tense abdomen and high blood pressure, there is high possibility of abruptio. So I would first go for clinical examination and go for a few blood tests to know the intensity or severity of the hypertension or preeclampsia, what is there, and advise a Doppler. so that we can rule out abruptio. We'll go for full biophysical profile. If time limit permits that, if the baby condition is okay and Doppler is reassuring, then we can go for steroid cover, else we would like to deliver the patient, because this much CTG seems to be pathological.
Madam, you rightly said this is a tense abdomen, and this kind of CTG indicates, this kind of variability. In fact, it's a loss of variability indicates it could be a eruption. And rightly said, being a tachycardia, we need to confirm our diagnosis. Most of the time, it's a clinical diagnosis as far as abruptio placentae with a blood pressure of 140/100. What we do, many a times ultrasound actually misses a abruption. So many a times what I teach my students also, it should be a clinical diagnosis, assess the patient, is she is having tachycardia, how much amount of pallor it is, the pallor, if it is not going well with the amount of bleeding. So are you thinking of a retroplacental clot? So all this clinical examination, first of all, you should do. And we may do an ultrasound. Sometimes the ultrasound misses the abruption. So you go for the complete blood picture. What is the hemoglobin? You do the coagulation profile. You keep the blood ready, correct the anemia, and address the accidental hemorrhage which is there in front of you. So depending on what are the cervical findings, would you like to go and do ARM for this patient? Would you like to go? Of course, this is a very pathological trace. So depending on the cervical findings, you have to take the decision what is the mode of delivery of this patient. So definitely your assessment will be depending on your clinical examination. So thank you very much for that. And of course, we have to remember that acute stress will be indicated by prolonged bradycardia, which is less than 80 beats per minute. There will be a subacute one when there is a prolonged deceleration to less than 80 with a third to half the time at the baseline rate. A long-standing hypoxia, these have already been described, which is a non-reactive trace, shallow decelerations, and gradually developing hypoxia where decelerations appear and accelerations actually disappear. So no accelerations and small decelerations are there. So this is also, it will take 1 to 2 hours for the acidosis to occur. So this is acute distress, subacute distress, long-standing distress, and gradually developing hypoxia. We come to the 7th case for Dr. Kamla. Kindly read out this case for us.
So this is almost an ECG with reduced variability and no acceleration or deceleration.
Yeah, it's like a straight line,
It's a straight line.
It's like a straight line, and as there are no contractions also, and in spite of there being no
but even if there are no contractions, still you should be having some, accelerations.
Yeah,
should
so no
always be there.
accelerations are there. You are seeing the reduced variability and no decelerations also. So let me tell you this case.
Dr. Surekha, may I also tell you that, as I mentioned, that it is dependent even on the fetal behavior. So even in the fetal crisis period, this can be the thing, and this has to be, reaffirmed by another CTG. So here
I'll just tell you the case, ma'am, so that we can discuss that part.
Yeah.
Yeah. So is Dr. Kamla there, or we should go ahead? Dr. Asha will just take up this question.
And Dr. Kamla is back.
Okay, Dr. Kamla, I'm going to tell you the case. As rightly said, this CTG is having, reduced or absent variability, no accelerations, no decelerations. She is a 31-year-old primigravida with 39 weeks of gestation, and she has gestational diabetes. Okay, it is controlled. Patient is not in labor. She came to you with absent fetal movements. Now, what is your management for this patient? It is having progressive decline in baseline, reduced variability. What would you do for this patient who is having gestational diabetes?
Thank you, ma'am. Thank you, Surekha, ma'am.
Yeah.
And patient is as a high-risk patient. She is gestational diabetes mellitus, and she is having 39 weeks. First, we go for her blood sugar. What is her blood sugar? And we go for USG Doppler, as we show that patient is not in labor and her fetal heart is non reassuring pattern, CTG is non reassuring, and without contraction, baby is hypoxic. So we should go for termination of pregnancy.
Yes, ma'am. But definitely we would like to do her blood sugar and find out, whether she is in hypoglycemia, and that is why this kind of CTG is there. So she is high risk pregnancy. We need to admit her. That is the first message we would like to give the audience, that this patient should not go home. She has to be admitted with you. Certain resuscitative measures may be needed for this patient. This is just a snapshot in time, as rightly said by Dr. Mitra. Maybe the baby is asleep. Is there a hypoglycemia? We would like to take a longer tracing maybe and find out if this kind of the lack in variability is persistent, or is there any other dip or deceleration which will tell us. And of course we need to assess the patient, what is the cervical score, and then we would like to decide what would be the mode of delivery for this patient. But definitely admitting the patient, evaluating the patient, already completed 39 weeks, so we need to terminate the pregnancy, and mode of delivery will be decided by the cervical findings also, apart from the CTG. So we come to the last.
Loss of fetal movements should never be ignored, and immediately I would do a vibroacoustic stimulation test and establish it, and then take it from there.
Yeah, thank you very much. And we come to our last case for Dr. Prerna. Can you read this case for us, ma'am? The CTG.
What I'm seeing in her, this is a normal baseline, and with there is a variability, normal variability, and normal deceleration and acceleration. Looks like a normal to me.
So you think that this is a normal, everything is normal in this patient?
Except the baseline tachycardia, except the tachycardia. Tachycardia is
I think it's around 120 or 100, 120. Now let me tell you this patient, the second gravida with a previous vaginal delivery, 28 years old. She came to your hospital because she was given advice of LSCS, a cesarean section, in another hospital. But she is your patient. She does not want to get the LSCS done in that hospital. So she came to you. Now this CTG is taken by your nurse, actually. Okay? And this is what is seen. So what do you think?
I think why the patient is advised LSCS in other hospital, I have to find out that reason. And she is 28 years old. First is normal delivery. How much is the
and let me tell you, the baseline here is only 100. It's 100.
It's 100. Means it's the bradycardia. Baseline is little low, but we have to repeat CTG properly. Number one.
Okay. Anything else come to your mind, ma'am, with the 100 such kind of
maternal?
Ensure whether it is the
definitely. All the panelists are right on track there when they think that it is looking normal, but why the baseline is 100? Is it a maternal?
Taken properly by
CTG has been taken by a nurse, and a doctor hasn't examined the patient. So first of all, you need to examine the patient yourself before taking any decision just on the basis of this CTG. Somebody sends to you a CTG on the WhatsApp and you say, okay, the resident, you tell them just go ahead with the cesarean section because the baseline is 100. That is not what the take-home message. Yes, ma'am.
We have to see what the patient condition is, whether patient is in labor or not labor, and what is the gestation age, and we'll repeat that CTG.
And yourself place the CTG. You have to palpate the maternal pulse and find out whether this is the maternal recording. And yes, on examination, the doctor did not localize the fetal heart at all. And this is the tracing. It was the mother's tracing. Actually, it was an IUD. So caution for interpreting anything is to carefully auscultate the fetal heart, place the probes correctly, the tocodynamometers correctly, and you feel the maternal pulse simultaneously before taking any decisions. So that is what we want to give, and all the panelists have rightly said that this could be a maternal pulse, and that's what. So I would not, because because of the time and all our participants are waiting for the quiz, so I just would go through some cases before, just show you the traces. This is one trace of a 25-year-old low risk with labor pains in 4 hours. Admission CTG is just showing these decelerations, which are late decelerations. So in these cases, what to do if the baseline variability is normal, only early decelerations are seen. So again, management is assessment of the labor, how, what is the progress, what is the stage, and then re-evaluating the CTG and, taking not the decision based on the CTG, but holistically, what is the progress. If she's already in late stage of labor, you may just monitor this patient and not get panicky by these early deceleration.
The important point in that graph, Surekha, was the mirroring. With every contraction, there is a deceleration. Yes. It's a V shape, and every deceleration, there is variability.
But so it is coming back to normal. So we have to remember
not only baseline, I mean to say, look at the deceleration. There is variability, beat to beat variability in the deceleration also.
Yeah. So rightly pointed out, the variability is persisting. It is there in the deceleration also. So we don't have to panic when we see these kinds of early decelerations. Yeah, definitely. So this patient actually had a vaginal delivery and healthy baby. We monitored the patient well, and the delivery progressed well. So what is this? This is actually called as a pseudo-sinusoidal wave pattern, as you can see here. And this is a patient who came to us at 40 plus 4 weeks of gestation with pain in abdomen. And what could be the management in such kind of patient? Because sinusoidal and pseudo-sinusoidal, how do you differentiate? Actually, it resembles the sinusoidal, but there is jagged sawtooth appearance. And most of the time, it is lasting for a small period of time. It doesn't exceed a 30-minute period at all. And sometimes it is just because of the analgesia you have given to the mother. It may just because of the fetal movements or sucking movement. And thus, you don't have to, take decision on such a small CTG. You have to take a longer CTG to find out if this kind of sinusoidal or pseudo-sinusoidal is persisting, and then only you should take any decisions. So these are our take home, that you do not, you treat the patient and not the CTG. Your CTG is there as a diagnostic tool, which you have to interpret correctly depending on what your findings are and what your case is, and overall assessment will tell you what would be your mode of action. So with that, I would like to stop share, and I would like to thank all the panelists who have very nicely given the take-home messages to our audience with their wonderful knowledge about the CTG and interpretation of labor and the progress of labor. Thank you very much. We'd go ahead, Dr. Mitra.
Thank you, Dr. Surekha and Mitra ma'am, Dr. Taruchaya, Dr. Manju, Dr. Ajay Sharma sir, Jodha sir, Dr. Raksha Sharma for being here, Dr. Madhuvarla ma'am for being here and, making it so lively and interesting for everyone, along with good take-home messages. Thanks a lot. Thanks a lot. And now, everybody has to get ready for the quiz. So
the quiz is actually very, very simple. Now, in retrospect, I think it is a very simple quiz. I request all the participants, even the panelists, even all the faculty, that they should download the Kahoot app, Kahoot, Kahoot, from the Play Store. I will type it in the chat box so that everybody is able to play the game. Kahoot. This is the Kahoot app. Once you download it, you will be asked to share. The Kahoot app will ask you the PIN. Let me go to the app.
While you're doing that, I want to say that the panelists were very nice. They, explained all the graph so well, and I think जितना ही क्या कहते हैं वो गाना नहीं है, CTG is एक पहेली है तू, तो completely पूरा patient देखो, obstetric checkup देखो और CTG को समझ के interpret करो. But it was a wonderful, evening today. So
thank you.
The game pin.
So the game pin has been generated. So you may be looking at the app and it is asking you for the game pin. The pin is 972865. So I repeat, as soon as you put the pin, the players will be entering. So Taru has entered, Sumana is there, Bobby. 3, 2, 1. We go to the first question. What is the baseline in the CTG? Is it 140, 145, 150 or 155? Four, 3, 2, 1. 12 of you have given the right answer. So Taru is topping the chart, followed by Chanchal, Bobby, and Dr. Sumana and Amu. So congratulations, we move ahead to the next question. What is the obvious abnormal finding is this CTG? Is it an early deceleration? Is it a late deceleration? Is it a variable deceleration or a prolonged deceleration? 4, 3, 2, 1. What is it? Oh, wow. 7 of you have given the right answer. Very nice. So again, now we have Taru again topping, followed by Bobby. Mitra ma'am is moving up. Swati has moved up. So we go ahead with the next question. Next question is, how would you interpret this CTG? Is it reassuring? Is it unequivocal, non-reassuring, or is it pathological? How is it? 3, 2, 1. And the answer is reassuring. 9 of you have got it correct. Congratulations. Very nice. Taru is still at the top with 2,375 points. Mitra ma'am has moved up. Bobby has moved up. Sona has also moved up. Fourth question, what is the obvious abnormality in this CTG? Is it a sinusoidal wave pattern? Is it a baseline tachycardia? Is there a shouldering? Is there increased variability? What do you think it is? Four, 3, 2, 1. It is a baseline tachycardia. 7 of you have given it right. Congratulations. And yes, now Mitra ma'am has moved up. Taru is in second place. And then followed by Sharma and Amrita. Now, moving on to the next question. What does this CTG show? Is it a sinusoidal wave pattern, baseline tachycardia, reduced beat-to-beat variability, or a hypertonic uterine contraction? What is it? Little bit of confusion, maybe. What is the obvious thing? Okay, it is a reduced beat-to-beat variability, and 7 of you are right. Now let us see. Okay, Mitra ma'am is still in the top, followed by Taru, Sharma, Bobby, and Sona. So now we move on to the next question, the 6th question. What are the arrows highlighting in this CTG? Is it a later deceleration, early deceleration, variable deceleration, or a combined deceleration? What is it? Lot of time. 5, 4, 3, 2, 1. Okay, it's a late deceleration. 11 of you are right. So that means the CTG workshop is successful. And who is topping? Wow, Taru has moved up. So competition between Taru and Mitra. And very nice, 3909 points for Taru, followed by Bobby, Sharma, and Dr. S. Congratulations. So 7th question. What is the arrow highlighting in the CTG? What is it? It's early deceleration, late deceleration, prolonged deceleration, or variable deceleration. What is the answer? So quickly, we are having answers here. Lot of time still remaining. 3, 2, and 1. 12 right answers. Wonderful. The answer is prolonged deceleration. Again, I must say that the CTG workshop is successful. With Dr. Taru still at the top, now Bobby has moved, pushed Mitra down, followed by Sharma and Dr. S.
That is because I am slow.
No, 8th question, 30-year-old at 35 weeks, she's fully dilated. You see the CTG, whether now you would like to affix the fetal scalp electrode in this patient. There are decelerations. Your answer, whether true or false. Yes or no? 10 answers already there. Answer is false because she is being a 35-year-old, 35 weeks in a preterm. We would not like to fix the scalp electrode. So 6 of you are right. Let us see the answer. Oh, Bobby has moved up. Taru has gone on the 3rd place. 2nd place is Mitra. Then Priyanka and Swati has come up. Very nice. Congratulations. We moved on to the 9th question. 30-year-old, 40 weeks of gestation, augmented by oxytocin, 8 centimeter dilated. What to do next? There are decelerations. You would watchful expectancy, be alert, be vigilant. You stop oxytocin, left lateral position, give Terbutalin. You shift for LSCs immediately. You wait for full dilatation and apply forceps. What do you do? Answer is stop oxytocin, left lateral position, and 9 of you are right. So again, we would give credit to the workshop. Oh, Mitra ma'am has come up now, followed by Bobby, Taru, Priyanka, and Sharma. We move on to the last question. This is the last opportunity. 24-year-old G4P3, 40 plus 1, 4 centimeter dilated. What do you do next? You do an immediate C-section. You observe for development of other deceleration. You augment with oxytocin. You do a fetal scalp sampling. So quickly we have answers. Great. Answer is you have few deceleration. So you would like to observe for development of other deceleration. Only 2 of you are right. Let us see what is the score. Taru is 3rd.
Yeah.
Bobby is 2nd. I can't give Dr. Mitra the prize because she is the one who has done this workshop.
No, it is the credit is to all the people. You and Bobby.
No,
and
we
Taru
should Bobby, then Taru, and I think let's see who else was there.
But
so
Dr. Surekha.
Yeah.
Dr. Surekha.
Yeah.
I am Bobby, so you cannot give me the prize as well.
Oh,
wow.
That's my nickname, so I put it there.
I was thinking
Bobby and Mitra is out, so the
I'm
first
lucky to
prize
have
goes to Taru.
Taru.
Yeah. And
Oh, thank you so
I was
much.
thinking of putting my pet name also, Shabbu. But then I thought, no, yeah, it is. I should come with my name.
क्या है मैम आपका
प्राइस
nickname
क्या है
क्या
तो
है?
बताओ
मित्रा मैम,
प्राइस
Yeah,
what's your
कुछ
nickname?
प्राइज क्या देंगे आप?
Shabbu. I didn't put it. I put my real name.
मैम प्राइस क्या दे
I
रही हो?
just put my nickname just to see the fun.
Yeah.
Yeah, so definitely it was wonderful, I think. And I would now like Dr. Mitra to conclude. Thank you, participants. We are having
Thanks to Bobby.
125. We are having
Thank you,
125
Taru ma'am.
participants
So,
still. It is a great
enjoyed.
enjoyment.
first of all, I must really give full credit to these 2 vibrant ladies, Dr. Surekha Taide and Dr. Asha Jain, their conception, then their nurturing, and then their delivering. So they are perfect obstetricians, close to my heart, very, very close to my heart. Dr. Asha, I have known Dr. Surekha so closely, but it was a very, very nice experience to interact with you. directly on this podium. And Dr. Surekha, obviously, then please don't consider me partial, but I think in their own right, these two wonderful conveners need to be really, supported with in every possible way. The academics that is being done and the level of knowledge that has been, shared and improved for everyone, including us. Whenever we take a class or we give a lecture, we ourselves benefit. And thank you so much. I must thank my FOGSI team who are there to back us always. Our guests today, Dr. Alpesh, Dr. Leela, Dr. Veena, Dr. Anju Soni, they set the ball rolling in a very encouraging way. Then all our chairpersons, all the president secretaries from Rajasthan societies, it has been a wonderful, session. And you are really very, very vibrant, and it was a pleasure that, if it is not your case and you are coming up with interpreting it, that's a very good thing. And Dr. Preeti, all those I can see, I have to say my thank you, and to Jagsonpal for always supporting us in our programs. I do hope that whatever time we have spent today, it goes in good patient care. So let us not be, afraid, and let us really look at the dil of the fetus and understand कि क्यों कम धड़क रहा है, क्यों तेज हो गया, और हमने क्या गलत कर दिया. Thank you so much.
Thank you very much.
Thank you, Mitra ma'am. Thanks a lot. Your words really mean a lot to us. Thank you for our maiden of, jointly, this is the first meeting we've done, and you have been so kind to make it your committee activity. Thanks a lot. Thank you, Rajasthan. Thanks, Dr. Surekha. Thank you, Jagsonpal, everyone. Hope to see you again in our next webinar.
Thank you very much. We'll also like to thank from Jagsonpal, Mr. Vijay Kumar. He is going to give a thanks.
I'll take
Thank you, respected faculty and attendees. A new brand emerging from Naari division of Jagsonpal, PRORETRO. Me and my colleagues seek your support for PRORETRO, that is micronized dydrogesterone 10 mg tablet, assisting motherhood, delivering happiness. And for the management of fibroids, we have Zone 25 and Mifepristone 25 mg, and we look forward to your presence in our further programs as always. And from the whole team of Jagsonpal Pharmaceutical, we all wish you a very happy and a safe Diwali. Thank you very much.
Thank you very much. Support team, now you can end the meeting. Thank you.
Thank